Good evening, everyone. We're very excited to welcome you today for our webinar. I'm Dr. Cara. I'm the clinical lead for the acute medicine team at the Princess Grace Hospital and clinical director for medicine and medical specialties at the Royal Free Hospital. We've got two fantastic presentations today with two excellent colleagues. So first, we're gonna have Dr. Imran Manan, a senior consultant at UCLA in geriatric medicine and acute medicine, and one of our core consultants in the acute medicine rota of the Princess Grace Hospital. And Imran is going to talk to us about cognition. And Dr. Manan is going to be followed by Dr. Chauhan. Dr. Dev Chauhan is a senior geriatric consultant and clinical lead for the Department of Geriatrics at the Royal Free Hospital and one of our core members of the acute medicine team at the Princess Grace Hospital. Before we start with our presentations, I'd like to introduce you to Dr. Gabriella Cox, who is the head of medical services in HCA in W1 campus. And therefore, she's the operations lead for the acute medicine service at the Princess Grace Hospital and the affiliated medical services. And Dr. Cox has a slide to give us a brief overview of the medical services in W1. Thank you.
Thanks, Dr. Cara, and welcome everyone this evening. It's a pleasure to be able to host you all this evening. And before we get to our wonderful consultant presentations, I thought it would be useful to give you a one-slide snapshot of our medical service. As Effie said, my role sits at the Princess Grace and the Harley Street Clinic. We sometimes reference that as the Harley Street campus, and our medicine service certainly transcends that whole campus. You can see there's a comprehensive offering from our medical outpatients, our day unit activity, which includes a specialized endocrine investigation unit at the Princess Grace Hospital, and inpatient activity, where largely our medical inpatient activity sits at the Princess Grace Hospital. I'll just walk you through some of these colleagues, these columns, to give you some more detail about these, the service. So we have a range of medical outpatients sitting across the campus, but it would be safe to say the mainstay of our physician outpatient activity is at the physician's clinic, which sits at 13 to 14 Devonshire Street. Patients that visit the physician's clinic have access to over 60 consultant physicians across all our medical specialties, and links with state-of-the-art diagnostics in the same building. Whether your patient has a single problem that they need to see a specialist about, or a much more complicated medical presentation that requires multi-specialty input and an MDT, the physician's clinic is perfectly positioned to deliver that level of care for your patients. Both our consultant presentations are delivered by Imran and Dev, who are consultant geriatricians, and we've recently launched an Aging Well service at the physician's clinic, which delivers a comprehensive geriatric assessment for the more complex older age patients that you might be seeing in clinic. And there's a much more detail about that new service on the web pages under complex and elderly medicine at the physician's clinic. Our day unit and an endocrine investigation unit at the Princess Grace allows us to support medical day cases, whether that be for a simple iron infusion or other treatment or investigations at the Princess Grace Hospital. And our dedicated endocrine unit delivers dynamic function testing with our full-time endocrine CNS. Given this is our acute medicine webinar series, it would be remiss of me not to highlight our fantastic acute medical service, and that's delivered by two main pathways. the rapid access clinic, so an outpatient service for over 18 for patients that are fit to be seen in an outpatient setting, but certainly require more timely assessment by a consultant physician. And we can deliver a same or next day appointment with links to diagnostic appointments to be able to see and support diagnosis of patients that you have more concern about, that need that timely assessment, but don't necessarily fall into an inpatient referral. That clinic currently runs Monday to Friday in the evenings, but ad hoc appointments are always worthwhile reaching out to us to see if we can deliver that. And there's a dedicated inbox and dedicated phone number for that service. You might well be more familiar with our acute admission service to the Princess Grace. That's delivered by 9 acute medical consultants led by Dr. Efikara, our chair this evening. And that's a 24/7, 365 days a year service for patients who require urgent medical inpatient care. We have a dedicated acute medical ward, and the consultants deliver twice daily rounding. We have a daily MDT and a dedicated first hour pathway for all our acute medical admissions, such that their patients are seen in a timely manner. The initial investigations and initial treatment is started within that first 60 minutes of arriving with us. You might well be familiar with our centralised medical concierge centre, who do a phenomenal job in supporting acute admissions. But we also offer at the Princess Grace a direct number to support clinician-to-clinician discussions and referrals, and that is what's listed on that column. Rest assured, this slide will be shared with you after the presentation, so you can use it as, I hope, a useful resource and signpost to the referral details. I'll pass you over to Dr. Mannon, who's going to speak first, and thank you once again for joining.
So, good evening, everyone. Very nice to meet you virtually, although I can't see anyone. Welcome to our acute medicine webinar with a focus on geriatric medicine and frailty. So my name is Imran Manan. As mentioned, I'm a geriatrician, but also acute physicians and general physician over at the Princess Grace and Physicians Clinic. And today I'm going to be talking to you about a brief overview to generate conversation, questions around cognition, which is often a presentation which is thought about in patients, worries patients, and can often lead to a lot of anxiety within carers, families, and the individuals. So one of the things we do is we look at people who may be quite well, and the concept of a geriatrician is, of course, we deal with advancing disease, developed multimorbidity, but we want to identify those who are at risk and try and intervene early to see whether we can make a difference. So frailty has different ways of presenting, and I thought I'd just give an overview of what the pathophysiology and the theories behind frailty are at the moment. So as we know, it's a multi-system condition, and there are kind of several theories from a research angle which is being looked into at the moment, which may help derive potential therapeutics in the future. So inflammatory aging is the concept of chronic inflammation in older age, leading to a much higher predisposition to those who are vulnerable, develop into frailty. So this is about chronic inflammation in certain groups, elevation of IL-6 CRP, leading to frailty. The theme of senescence, so thinking about cell death and the kind of remnants or the bad bits being left over and then entering at the cellular level is the other area of interest, in addition to mitochondrial drop, so a lack of energy. And all of these are important because they have significant clinical impact. So they lead to what the symptoms are. So exhaustion, tiredness, cognitive impairment, and a general decline. So frailty is a reduction in function, and we can use a multi-domain way of assessing those who are at risk or those who have a diagnosis. And this brings us to the theme of homeostenosis. So the graph on the right-hand side demonstrates that not all individuals are frail. So we may have a very well 85-year-old who is resilient, who after a minor illness such as a pneumonia, a urinary tract infection, has a relatively good recovery, is able to get back to the baseline, and is able to continue to perform their daily activities as they were before. So those are those individuals who are not frail. However, those who are frail have a reduction in capability and adaptation. So the same minor stressor will lead them to have a much deeper illness, which lasts for longer, and they may not recover back to how they were before, and therefore permanently have an impact on their function, their cognition going forward. So we want to be identifying early those who are at risk to prevent that decline. So there's an opportunity for us to intervene. So just trying to use a case presentation of a common symptom, I guess, that comes about, and that is of brain fog and a loss of edge and something not quite right. So we have an 82-year-old who's otherwise, doing very well, and has noted that the memory is not quite right. And this is often presents in different ways and causes much more anxiety to individuals and their families because of what they're worried about and the impact of future planning. So the question is here, do they have dementia? Do they have a diagnosis of mild cognitive impairment? And it's often difficult to make assessments in those who do have a high education cognitive baseline, and what can we do to help them determine what is going on. So the initial marker is 28 out of 30, which is normal range. They have this concept of, presentation of brain fog, and the end of the bed test is that they're relatively robust. So I'm sure we all know about the medical kind of diagnostics, etc., to be done. So, blood tests, imaging, scanning, but there are other bedside tests or markers that we use to help determine those who may be at risk of frailty. So the timed up and go score is used actually across not just us, but neurologists, to a very simple test to identify if someone does have that slowing down of function. So it's all, of course, determined on their underlying comorbidities, kind of severe degenerative osteoarthritis, etc. But the timed up and go test is performed with an individual sitting at a regular seat, getting up, walking for 3 seconds, and sitting back down, and over a period of 3 meters. So the cutoff, with a bit of flexibility, is 12, and anything over this may indicate further risk of future falls and frailty. Grip strength has been historically used using quite a old-fashioned equipment called a dynamometer, which assesses essentially sarcopenia. So they press and it gives various readings in kilograms, and anything below 28 for a male and 18 for a female indicates sarcopenia. So sarcopenia is a global reduction in muscle function. It's not always unique to a neurodegenerative condition. It's a marker of frailty. And those who are sarcopenic really do have a very high risk of metabolic failure, fragility, and a risk of toxicity. And the one which is probably the best predictor is gait velocity. And this is measured by an individual using their usual methods of mobilization, so either unaided with a stick or a frame, to walk over 4 seconds. And we use a calculation then over the time it's taken to give a score. So anything under 0.8 is indicator of someone at risk of physiological failure. And of course, as geriatricians, we focus on clinical examination. We're focused on the history, but also the medications. And in this individual, it's important to have a think about the medications. So I want to bring the concept of acetylcholine burden scoring, which they're relatively easy to use tools to think about what could be contributing to the brain fog, to the confusion, and to the other symptoms. So looking at this list, so a score of 3 or above is deemed a high burden, but of course there are traditional medications which have particularly high load, such as amitriptyline, often used for a variety of reasons, oxybutynin for incontinence, and other medications such as frusemide, which has a has a mild but not insignificant burden. So the important thing is this individual, there is a cumulative effect. So all these medications are adding together to give this burden. And for me, it's important that we try and, before going ahead to all the more in detail testing, that we have a think about whether we can try and reduce the cognitive risk, or is there anything reversible we can do for these individuals? And the mechanism of these medications, they compete in the kind of presynaptic membrane. They competitively bind to M1 receptors, and the concept of reduction in amyloid clearance is an important factor in how they have the effect on cognition, and we'll talk about amyloid shortly. And why is this important? It's because individuals are at risk when they have a high score, a high burden, to an increase in dementia and transition of dementia. So those who may have mild cognitive impairment, who have had further stresses, are at increased risk of developing dementia. There's something we can do about this. The evidence shows a score more than 3 leads to a 46% increase in dementia transition. So it's a big risk and a big modifiable risk. And what can we do before thinking about further testing? Of course, deprescribing and thinking about alternatives is important. So changing the amitriptyline to sertraline, oxybutynin to mibegron, and we wouldn't be geriatricians without thinking about exercise resistant, intensive resistant training tailored for the individual, and nutrition. Often, over-the-counter medications, have quite a marked significant toll on individual cognition. So hopefully the message here is to think, is there anything we can do to try and reverse and reduce the burden and the risk for this patient? And that brings into a very brief overview of where we are at in terms of updates in 2026. So increasingly, the use of biomarkers has been introduced for diagnosis of dementia, Alzheimer's dementia. So the p-tau127 is increasingly used as a blood biomarker to identify those as part of the kind of, I guess, multidimensional assessment trying to diagnose Alzheimer's early. The p-tau 127 has a 92% accuracy for amyloid. And of course, it can't be routinely used at screening, but those individuals who are presenting with symptoms, it really is a good opportunity to provide confidence to that diagnosis. The reason why this is important is because therapeutics have progressed. Lots of discussions about lecanemab, which is one of the new medications for early onset Alzheimer's. And this is, again, focusing on amyloid. So amyloid beta is broken down to several parts, including the monomer, the oligomer, and protofibrils. And lecanemab, which is a monoclonal antibody, targets protofibrils and prevents the deposition of these amyloid plaques. There's some controversy with the studies because they have shown a 27% slowing of cognitive decline, but they're not without their risks and not without quite significant and high intensity monitoring. So lecanemab, which, as mentioned, mentions the amyloid plaques, so the protofibril stage, has a relatively high risk of complications called the amyloid risk, which may be edema for E and H for hemorrhage, so microhemorrhages, which means that those who do start these infusions, if they are eligible, will, in addition to having their PET-CT, need regular scanning to make sure that there's no evidence of microhemorrhaging, which may actually negate the benefit of the medication in itself. And the treatment isn't without quite a big impact on the individual. And as it's shown you've been aware, NICE have not approved this. And I think it, however, provides an opportunity for those in the field to think about further diagnostics, which may have a much therapeutics, which may have a much reduced side effect profile. So hopefully we're here to help. There are lots of older people you manage. We're here to help those with complex presentations with their symptoms, which may not quite clearly fit within the clear diagnosis. And the other aspect, as mentioned, was the aging well service we're delivering. I have a special interest in preoperative optimization from a physician point of view. So my aim is to try and get as many people, older people with morbidity and complexity, to have surgery to live a meaningful life. So we work closely now. I think hopefully the days of just having a pre-assessment and clearing from a cardiac perspective has moved on, and we can have a much more nuanced discussion, including shared decision making with individuals, and perform a very thorough and detailed comprehensive geriatric assessment to work with anesthetic surgical colleagues and the patient to minimize the risk of complications, get them through surgery quickly, and get them out of hospital and home as soon as possible. So I've been involved from my work on developing these services through the concept of prehabilitation. So there is now research is evidence that prehabilitation, so targeted strategies before an operation focusing on physiotherapy and nutrition, has a results in reduction in complications post-op, and should really now be the gold standard for those undergoing surgery with complexity. So thank you very much for listening. Very happy to take questions shortly, and I'll hand over to my colleague, Dev.
Thanks, Imran. That was a fascinating topic and conversation. I'm sure everyone enjoyed that topic, and feel free to keep your questions ready for the end. I'm not the most tech savvy person, but I'm going to share my screen now. Do shout if it's not visible. But yeah, so my name is Dev Chauhan. I'm a consultant geriatrician and physician. I'm the clinical service lead at the Royal Free Hospital, do clinics at the Physicians Clinic and acute medicine with the team led by Effie Cara at Princess Grace. Gabby's been giving us great support in launching our Aging Well service. And I think Imran's kind of typified the patients that we want to see and be getting referred from you for a complex geriatric assessment, for your patients that are being referred for surgery but have frailty. How can their polypharmacy be reviewed? How can they be optimized? And hopefully we could be working better together. But over the next 15 minutes or so, I'm going to be talking quite quickly through the challenge of osteoporosis, the scale of the problem, a touch on the pathophysiology, the latest evidence base, what are the treatment options, what should we be giving first line for our patients. But it's obviously not just algorithmic medicine, and how do we tailor the treatment options, delivering personalized care? And osteoporosis fits amongst many specialties, including primary care. So what's the role of a geriatrician in this? What are the typical type of patients you might refer to Imran or I? And I'll tie that all together with a few cases towards the end. So the way I see life as a geriatrician, and when I see a patient in front of me, I always try and think, how can I support this patient to live life like the Queen or the King? But what do I mean by that? We all remember the Queen fondly. She lived a very independent life. She walked fairly independently. As far as we know, she didn't have many years of life living with disability. She wasn't yo-yoing in and out of hospital. We don't think she had polypharmacy. And when she died, she died in a place of her choosing in Balmoral, surrounded by her loved ones, and had what we hear was quite a dignified death. And that's how I like to help my patients achieve that, not going in and out of hospital, and to maintain their independence. So why do I bring that up? Well, it was typified by the CMO's annual report in 2023, which was about health in an aging society. And the message was about how can we be more proactive and delay disease onset and screen and detect problems before they happen. Because osteoporosis, as we know, is a big, big problem. 3.5 million people in the UK have osteoporosis today. But how many know they have it? Because it's asymptomatic. And we have every 3 minutes a fragility fracture is happening. So in the space of this talk, 20 people have had a fragility fracture. It cost the NHS a lot of money, over £4 billion. And we see over 70,000 neck or femur fractures every year. Right now, today, there are 4,000 people in NHS beds with a neck or femur fracture. And a neck or femur fracture, it isn't just a neck or femur fracture, it's so much more. It just typifies frailty, what Imran was talking about. 10% of these patients die in the first month, 33% roughly die within a year, and 50% don't go home after that problem happens. So osteoporosis is a massive problem. It's asymptomatic. It leads to big consequences. So how do we screen for it? How do we detect it better? And how do we treat it in the best way possible? And it's everyone's problem. You guys see it in primary care all the time, but which patients do you refer to us as geriatricians, or to rheumatologists, or to endocrinologists, because they're putting everyone on steroids, and so forth. So it's everyone's problem. We all see osteoporosis, but the goal of the talk is to think about which patients you'd be referring to Imran and I. Recap on healthy bones. We all know we need good amounts of vitamin D, calcium. Estrogen is very protective on our bone density, and that's why we know that postmenopausal females, that drop in the hormones causes a drop in the bone density. It's good to have a good diet, balanced diet, regular load-bearing exercising. These are all things that make healthy bones. Another quick med school type recap of vitamin D pathway. We know it's produced in the skin and through diet, and that gives you cholecalciferol. That is then hydroxylated in the liver, which can then be stored. And then the kidney, it's an important part because that activates the vitamin D to calcitriol. And that's why if you have a problem with any one of these things, either dietary insufficiency, lack of sunlight exposure, malabsorption, liver problems, people with CKD, that can lead to a problem in the vitamin D synthesis and activation, and that can then lead to osteoporosis. You obviously then need to think about the links with the parathyroid hormone, but that's a sort of whistle-stop tour to refresh your mind on vitamin D synthesis. A couple more buzzwords for us all to remember. We have the osteoblasts and the class and the sites. I used to always think about B as the builders. So the osteoblasts are the cells that build bone, and that's what lays the foundations for healthy bones. Whereas osteoclasts, they're the sort of killers. They cause the resorption of the bone. And an imbalance in this pathway is what leads to osteoporosis. So what are the risk factors? Which people should we be thinking about screening for osteoporosis with FRAX scores and DEXAs, which we'll come on to? So we know it's more common in females than men. And again, that's typically postmenopausal females due to the drop off in the estrogen postmenopause. We know slim people, people with a low BMI, their bone density also is reduced. People on steroids, people that smoke, alcohol, diabetes, and then all the other problems that cause malabsorption, such as celiac disease or inflammatory bowel disease, and then problems that we mentioned to do with the vitamin D synthesis and activation, so chronic liver disease or chronic kidney disease. So how do we diagnose osteoporosis, and what should you be doing in primary care or in private GP services? So when you're doing your assessments, your health MOTs and screening, I do it for certainly all the patients I see as part of a comprehensive geriatric assessment. So a whole part of my assessment is thinking about their bone health. I calculate a FRAX score. I have a low threshold to arrange a DEXA scan and plug that back into the FRAX score. I think about their falls risks, and we'll come on to that shortly. But ultimately, we should be doing a FRAX score in effectively everyone after 50 years old. But what is FRAX? Well, FRAX was developed in 2008 by researchers in Sheffield. It ultimately calculates your 10-year probability of having a major osteoporotic fracture. And what are they? That's your neck of femur, your vertebral fractures, your humerus fracture, your distal radius, everything we see in A&E on a regular basis. And it's very easy to calculate. You Google it and enter in their demographics, their age, date of birth, their height, their weight. Most importantly, you want to know if they've had a previous fracture, their family history of fractures, and whether they smoke or have a history of rheumatoid arthritis, alcohol intake. So it's quite easy to diagnose, right? But ultimately, I think the problem with a FRAX score is that it doesn't calculate many of the things that Imran and I would be seeing in a lot of our patients. For example, your falls risk factors. This is based on the FRAX score is looking at your bone health and your risk of having a fracture purely from a bone perspective, looking at your risk factors from osteoporosis. But it's not asking you more quantifiable information. So, for example, it's not asking, do you have unexplained or untreatable orthostatic hypotension where you take midodrine and fludrocortisone? It's not asking about if the patient has visual impairment. It's not asking about if they've had a previous stroke and are hemiplegic and therefore have impaired mobility. So a FRAX score, I think you need to know when you're using it. It's helpful as a screening tool when you're comparing it for a healthy person with low falls risk factors. But you need to be thinking, for example, of its negatives, as with everything. So, for example, when it asks about have they had a previous fracture, the answer is binary, yes or no. It doesn't say, was that a neck of femur fracture, or did they have two fractures? There's binary choice. But once you do the FRAX, you can, especially in the private sector, quite easily get a DEXA scan, which a lot of our patients would want and expect because that gives you a more accurate picture of your bone density. And we know that that's quick and easy to do. And that T-score, which is a standard deviation compared to a healthy person of the same age as the patient, gives us an accurate representation of their bone density. And just a recap of the numbers, more than -1 to -2.5 is osteopenia. If it's more negative than -2.5, that would be osteoporosis. But if it's more negative than -3, that is your severe osteoporosis. And that's probably for your younger, healthy patients where you definitely want to be getting rheumatology opinion and ensuring you've done your secondary screen as to is there a secondary cause such as celiac or malabsorption that may have resulted in it. So for treatment, so the diagnosis we've kind of covered. Do your FRAC score, your bone density, DEXA scan, plug that into your FRAC score, and that will guide you as to your osteoporotic risk of fracture over the next 10 years. The most important thing for treatment and how I like to think about is the most important thing is get their vitamin D above 50. That is the single most important thing because we know that lots of the bisphosphonates particularly can cause hypocalcemia if they're not replete of vitamin D. It doesn't really matter how you get it to 50, and most physicians have a different algorithm. Some people give 40,000 units of cholecalciferol every day for 7 days. Some people do it on a weekly basis. But ultimately, as long as they're getting a loading dose of close to 300,000 international units, that will get their vitamin D above 50, and then you can crack on with your treatment options, which we'll come on to. But then I just like to think, what's their creatinine clearance? Because once that's worked out, if it's below, let's say 30, that rules out several agents. So when I see someone, I think, right, let's get their vitamin D above 50. Let's check that. Let's load them if needed. Let's have a look at their renal function, their creatinine clearance, because that will help me decide what's the best treatment for them. And then I like to think about all the contraindications for the medications that we give. And I've got a table which we can go through, but ultimately we all know alendronic acid has to be taken in a very special way. It can cause GI upsets. As with all bisphosphonates, you need to be counseling about osteonecrosis of the jaw. How is their dental hygiene? Have they had a previous gastric bleed? And then you want to think about the likelihood of their compliance. We know that if you have to take a medication every day, you're probably likely to take it. But if you have to remember to take it every Saturday in the morning, people's compliance may drop. Or if you go for denosumab, which is a 6-monthly subcutaneous injection, do you have confidence they're going to maintain it? And for that one in particular, it's very important because we know if you stop denosumab without any other treatment, that massively impacts your bone density, and it was pointless you having it in the first instance. And then you need to think about the follow-up plan. So that's what I'm alluding to in a sense, is that if you decided to give someone an infusion, you heard about our day unit at Princess Grace. So if you referred someone for a zoledronic acid for an infusion, what then happens in 12 months' time? If they're an overseas patient, are you confident they'll be able to carry on and get a future infusion? Are you then going to switch them to alendronic acid? So I think it's always important to think not just about the immediate treatment, what is going to be sustainable, what are they more likely to tolerate and be compliant for. So that's the sort of treatment algorithm I have in my head. So vitamin D treatment we covered, you need your 280 to 300,000 units as a loading dose. And then you need to maintain it with 800 to 1,000 units a day at least. And if they have renal CKD at least, or CKD 4-5, you'd want to be thinking about giving them the activated vitamin D because the vitamin D is not getting activated in the kidneys. And I would suggest referring to a renal physician to give them an appropriate dose of alpha calcidol if that's what's needed. So a very quick whistle-stop tour and recap of the common medications again. So you have the bisphosphonates, and I've got a diagram just to review how they work. But these are the cheaper options. They're often first-line options given in the NHS, but they're great. They've been given for a long time. They have very good evidence base. They reduce your risk of hip fracture, risk reduction in the region of 30 to 40% in most of the cases. But we have a lot of emerging research, a lot of newer treatments coming, and these are the anabolic agents because the bisphosphonates are anti-resorptive. So we want that, and I'll come on to the diagram, and that will explain things a bit better. But just a quickly to highlight the costs of these medications, particularly if you have a self-pay patient, you may want to make them aware that whilst romosozumab is becoming the first-line treatment for patients at a high fracture risk, it's the monthly injection, 2 injections a month for 12 months. That's close to about £5,000 a year. which is important to be aware of. So you can quote that when considering that. But that is very much the gold standard first line approach for females with a high fracture risk. I say females because that's the current NICE guidance for romosozumab, and that's where the evidence base is greatest, because their trials were done in females because of the increased prevalence of osteoporosis. But soon that will be rolled out to men as well, I'm sure. So I think it's easier to talk about the medications through this diagram. I'm not sure if you can see my cursor, but on the left, you've got you've got bone at the bottom. You've got osteoblast, the cells that build bone on the left in pink, and the osteoclast in a kind of turquoise. So the blasts are the builders, the clasts are the resorbers. And if we remember, the bisphosphonates are anti-resorptive. So they prevent the osteoclasts that are maturing at the top and going into the bone, they prevent them from getting into the bone. So they prevent osteoclast activity. We touched on denosumab, so just visualizing how that works. So the osteoblasts release rank L, and the rank L are those circles that then go and attach to the osteoclasts, and that's how osteoclasts mature. So if we block that pathway, you won't get activation of the osteoclasts, you won't get osteoclasts resorbing your bone. So again, that's an anti-resorptive treatment option. The romosozumab is a anabolic agent. Well, it actually works in dual function. It's a sclerostin inhibitor, but ultimately it has dual function on your osteoblasts and your osteoclasts. So it's predominantly a bone builder, and it works on this pathway here, the WNT anabolic pathway. But that's just giving you some oversight as to how the medications work. I think I did touch on this earlier, but ultimately, I've said that many different consultants, specialists, GPs see people with osteoporosis and are screening for it actively. But where I feel the added value of a geriatrician is delivering that personalized care, doing your comprehensive geriatric assessment to not just think about bones in isolation, but to think about falls risk factors, compliance, the side effects, their polypharmacy, their frailty, thinking about advanced care planning, and bringing that all together. Because a FRAX, again, is looking at your 10-year risk of developing a fracture. It may well be that the patient has a clinical frailty score of 8, and they may not be, you may not even think they'll survive 10 years to get the benefit of the medication. And I think bringing that all in together is where the role of a geriatrician best fits. So I've got 3 or 4 cases, and we'll try and run through them very quickly. I've tried to tailor them to our audience. So let's say GPs working in the private sector. So this patient's a 75-year-old lady. She was traveling from California. She was staying in the fancy Grosvenor House in Mayfair for 3 weeks. And she books in with LGP, which is next to the physician's clinic. And she booked in for a wellness check. And she says to the doctor, my mother died from a hip fracture when she was of a similar age to me, and I want to do everything I can from preventing a hip fracture. I don't have any medical problems. I travel. I do smoke a lot, 1 pack a day, and I drink some wine at night. So I guess this is not an engaging discussion for now, but I thought I'd explain the thoughts that run through my head. So how would I typically approach a patient like this? So I guess ultimately, if I was to do a FRAX score and screen the patient, I'm not sure that would satisfy her enough to say your risk of an osteoporotic fracture in the next 10 years is X, and the guidance says to have lifestyle modification or to commence treatment. Sometimes we know in the private sector, our patients are slightly more anxious or they want some more objective information. So I don't think a FRAX score in a patient like this would be enough. And we know it's quite easy for us all to get DEXA scans arranged. And so I would personally, in this instance, calculate the FRAX score, get a DEXA scan, look at the bone density, input that back into the FRAX because that makes it more accurate, and then be guided by the treatment line as to my next steps. And then you'd be thinking about, do they have normal renal function? Okay, great. That opens them up to all treatment options. If I give her romosozumab, is she going to be able to take it? If I give her denosumab, are they going to be able to get that in California? Probably. And so that's the thought process that would be going on in my head. So I would be doing a DEXA scan, a FRAX score, and then telling her to reduce the smoking and alcohol intake with the simple lifestyle modifications if she wants to take this seriously. So that was the first case I thought would be a common thing that you guys may be seeing where you work. I'm not sure how relevant this is to all the people on the call, but I thought we'll discuss it in any case. So this case is about a 65-year-old male who lives in a care home, and their private GP has been asked to go and do a home visit due to some concerns of delirium. But this is a very frail man. He's hemiplegic from a previous stroke. He's peg fed. He's minimally verbal. And whilst the nursing team were transferring him from the bed to the chair using the hoist, he sustained a fracture in his shoulder. They took him to A&E. A&E did the x-ray, saw that he had a fracture, advised a collar and cuff, gave him some cocodamol, but didn't really talk about bone health. And you came along to this talk and you were at the home visit and you thought, God, this guy's might have osteoporosis. What would you do? So I'm sure everyone knows, but I thought I'd run through the thoughts in my head. So I guess one approach is this is a frail gentleman who's had a stroke and is peg fed and is minimally verbal. Their clinical frailty score is likely 8. Their life expectancy could be 6 months, or the question we ask ourselves, would you expect this patient to be alive in 12 months' time? The answer may be no. So then why would you add to their burden of polypharmacy? They're peg fed. How are you going to give them alendronic acid? Do you really want to be taking them to the Princess Grace Day unit for an IV zoledronic acid infusion? What would you do in this situation? So obviously they need their analgesia. I think for me, the most pragmatic option would be to check their vitamin D levels, the parathyroid and calcium levels. I'd make sure their vitamin D level is more than 50. You can get liquid solutions, spray solutions for vitamin D, and that can be given via the PEG. I would potentially do a FRAC score to help justify my decision-making process, but I certainly wouldn't be taking this patient to a DEXA scan due to their mobility concerns. For me, I think that would be a step too far. In terms of the treatment options, we know that the bisphosphonates can increase your risk of GI bleeding, the practicalities of giving it via the PEG tube. So in this case, and for how I would approach it, obviously you'd be discussing their capacity and liaising with their next of kin. But ultimately, I think the way I would treat this is to ensure their vitamin D is topped up, make sure there was a safeguarding investigation as to how this patient had a fracture in a care home when they were being hoisted out. But ultimately, I think making sure you're looking at their analgesia, their quality of life, and in terms of fracture risk reduction, my focus would be on ensuring their vitamin D is above 50 and not going for the osteoporotic bisphosphonates. Case 3, and I've just got a couple more. So this is an 83-year-old retired architect, and they come to see you with worsening back pain. The patient's cognitively intact, they're independent, they're traveling a lot. So you arrange a CT scan and you find that they have 2 vertebral fractures. So you also organize a DEXA scan and you find that their T-score is minus 3.6. So if you remember the thoughts that are going through my head, well, firstly, I'd be thinking there's been no trauma. Is this an atraumatic fracture? I know they have a T-score of minus 3.6, but I think we need to definitely be ruling out, was this a pathological fracture versus osteoporotic? So they may have osteoporosis, but they could also be unfortunate and have an underlying diagnosis of myeloma. So I'd certainly be doing a myeloma screen, thinking about other cancers, looking at their vitamin D, then investigating their osteoporosis with a secondary screen. I'd do all the things we mentioned, calculating their FRACs. But ultimately, in this patient, they've got very severe osteoporosis. They're female, and so therefore they would be qualifying for romosozumab. And just to recap, this is for your most high-risk patients with a T-score of less than minus 3.5, really. The things to avoid it in is patients with a recent stroke or recent NSTEMI. And you're just thinking about the cohort of patients, would they be able to self-administer 2 subcutaneous injections monthly? The cost we mentioned, I'd be make that clear. Most insurers wouldn't cover that, so then that would be a self-pay cost to discuss and think about. but then you need to have a clear plan for what's going to happen in 12 months' time. So just a reminder, the romosozumab is the anabolic, it's the sclerostin inhibitor. So that's helping you build your bones and get your bone density better than minus 3.6. But once you've built it up, you can repeat your DEXA to see the gains, but then you want to maintain it. So then you may want to go for your alendronic acid to maintain those gains that you've had through giving the romosozumab for 12 months. Case 4. So this is a quick fire one. Ultimately, this is a 75-year-old librarian who comes to see you, and they've had several falls in the last 18 months. But this is a very independent person, but they also have end-stage renal failure, but they have peritoneal dialysis at home. They're independent, as I say, but their CT scan, like with the previous case, showed some new vertebral fractures. So I guess all the same thought process applies to the previous case, but the reason why I brought this up was to think about what we get a bit stuck when someone's creatinine clearance is in the 30s or lower. But resendronate allows you to go slightly lower, but really for patients with end-stage renal failure, obviously would be referring to our nephrology colleagues. There was more to make you aware that denosumab can be given into these cohort of patients, and there's certainly some emerging evidence to support that use. So I think, in summary, I just wanted to cover that I think osteoporosis is one of the most important problems. It's apparent in over 3 million people in the UK today, and most people wouldn't know about it until they have a fracture. And the time you have a fracture, we know that that increases your morbidity, your mortality, your quality of life. We recap the pathophysiology, how we would approach a diagnosis to it, some of the evidence base, and how I like to approach the treatment algorithm in my head. Don't have hair. And what's the role of a geriatrician? Lots of people see osteoporosis and can treat it and manage it. But for me, it's not just about managing their bones. It's about the holistic assessment of thinking about their falls risk factors, their polypharmacy, their likelihood of compliance with the medication, an advanced care plan, their prognosis. And that's where I see the role of geriatricians like Imran and mine. And so hopefully we'll be hearing from you soon. So that concludes my talk. Thank you all for listening.
Thank you, Dr. Chauhan, and thank you, and as well for Dr. Manan for the excellent presentations. We've learned a lot tonight. We've got 2 questions for the osteoporosis talk for Dr. Chauhan. So, what factors push towards denosumab versus odendronic acid? Dev.
Sorry, did you say why is there a push?
What factors would make you choose denosumab versus odendronic acid? How do you decide between the two?
Yeah, so for me, it's all about thinking about the risk factors and compliance. And I'm sure Imran may have comments as well, but alendronic acid is not suitable for older people in particular that have poor dentition, have a previous history of GI bleeds. And particularly if I saw a patient that I thought, God, if they had an upper GI bleed, they wouldn't be suitable for an endoscopy. So I'll try and preempt the consequences and side effects of the medication I'm giving. So alendronic acid is trialed and tested and been around for a long time. But for me, if a patient has poor dentition, has a risk of bleeding, I certainly wouldn't be giving it. Denosumab is definitely one of my more favored options because it's a subcutaneous injection. It then therefore it's given 6 monthly. It therefore doesn't contribute to polypharmacy. It still has the risk of osteonecrosis of the jaw to be aware of, but that would be my favored option if I was concerned about compliance or the risk of GI bleeding.
Thank you very much. What about when we stop denosumab? How do you protect patients from having the rapid decline in the bone density? How do you decide when and how many infusions of odendronic acid to give?
Well, that is a big problem, and particularly for patients that many of us have that are international, that are traveling or have multiple homes, is how do you maintain this medication? So, like with denosumab in particular, if your patient suspends it or doesn't take it, or you don't have a recurring prescription with them, it's a big problem. So for me, I have an alert on my phone, on my system that I use, so that every 6 months I first offer a repeat prescription, but I have an alert so that it makes me aware that if the patient hasn't collected it. But in terms of what you would do, I would get a repeat DEXA scan to look at the impact of what that's done to their bone density to see where we are, to then help me decide on the treatment options that are available for us. But that's why it's so important about patient selection. You want to be making sure that this is not a one-off injection. You can't then make it up by giving 2 zoledronic acid infusions. So it's all about picking the right patients and trying to find the right treatment for them that they will maintain.
One more question for Dr. Chopin, and then we'll move to the questions for Dr. Manon. So, Dev, after a fragility fracture, what timeline and what pathway you use for optimization of the patients and prevention of future fractures?
So I guess there's 2 parts. So on one hand, so Imran will know this better than I, but because he does ortho geriatrics. But ultimately, there was some worry that by giving bisphosphonates too early post fracture, that would delay bone healing. And each NHS hospital has different algorithms. When do you give the zoledronic acid, and so forth. But from a Royal Free perspective, and that's my NHS hat on, and the discussions we've been having with our fracture liaison service that we'll be setting up, the guidance that we've got is that you need to start treatment as early as possible. So we load with vitamin D as quickly as possible. So you could do that with 40,000 units daily for 7 days. So then you're done and dusted, and then start with your bisphosphonates if needed. So I think starting early is the key, but making sure you pick the right treatment for the right person, so the compliance is there and it's sustainable.
Thank you, Dr. Chopin. So, Dr. Manan, can we ask you for your reflections from your expert position on the recent Cochrane review on the anti-amyloid therapy for mild cognitive impairment and Alzheimer's disease?
Yeah, thank you for that. So I think what this comes down to is that there has been lots of discussion, both in the mainstream press and the academic community, about the quality of the previous studies with the monoclonal antibodies and actually the impact of this. And, you know, the recent data was, I think it was around almost 20,000 participants. And I think the conclusion was, yes, they can remove the plaques, but actually, was the benefit really significant or not? And I think a lot of people are concerned that they're not really delivering the impact of from a cognitive point of view. And I think the biggest thing is the risk factor. The bleeding risk is significant. As mentioned, all patients who are at risk of Alzheimer's also have other medications that make them at risk of intracranial bleed, such as anticoagulation and bleeding. And I think you could argue that I think what happened was that there's been a real criticism of the data analysis of previous studies, and I think it's made that very difficult for patients and probably the clinicians to talk about these treatments, because these treatments have to be used in those who have early signs of impairment, so those with mild cognitive impairment. So mild cognitive impairment is different from an established diagnosis of dementia. They maintain their independence. They have just subtle executive dysfunction. And I think it's made that conversation with the patient much harder because the benefit is not clear. In all of this, there's a big health economic cost, so either through insurance or through self-pay. These are heavily and high cost treatment plans. So not only are we talking about the monoclonal antibodies, but also the serial imaging, so amyloid PET CTs, MRIs at intervals. and I think the conclusion is not clear. But there's going to be some individuals who are really worried about dementia and want to try to do everything they can to try and delay and minimize their risk.
Thank you, Dr. Manan. So we've finished just about on time. We've learned a lot. Thank you both for the fantastic presentations, and thank you to our colleagues that gave their time to join us this evening. Gabby, Dr. Coxon shared the contacts, and if there's questions outside this talk, I'm sure that Dr. Chalkan and Dr. Manan can take the questions for their sections respectively. And please feel free to reach to us if you need any support to discuss cases or to refer cases either to our outpatient or services. We look forward to working closer with you. Thank you and have a good evening.